Right-sided pain, fever, nausea. That's what most people think appendicitis looks like. But those symptoms alone don't diagnose anything, because every week I see patients with textbook symptoms who don't have appendicitis, and patients with almost no symptoms who do. Today I'll explain how surgeons actually interpret symptoms, and why the pattern matters more than any single sign. I am a surgeon, and this video is for education only. It's not medical advice and not a way to diagnose yourself. Appendicitis is a clinical decision made using multiple sources of information. What I'm sharing here is how surgeons think, not how patients should self-assess. The problem with appendicitis isn't that people ignore symptoms. It's that symptoms are often discussed in isolation. Online, appendicitis is usually presented as a checklist. Pain here, nausea there, fever equals diagnosis. But the human body doesn't follow checklists. Every appendicitis can look vague. Late appendicitis can look dramatic. And many dangerous abdominal conditions overlap, almost perfectly in between. That's why symptoms don't function as answers. They function as signals, incomplete ones, that must be interpreted in context. And that gap between symptoms and diagnosis is where most confusion comes from. Most discussions about appendicitis focus on individual symptoms. Is the pain on the right side? Is there nausea? Is there fever? But surgeons don't diagnose appendicitis by counting symptoms. One symptom by itself means very little. Even several together can still be misleading. What matters is not whether a symptom exists, but how it behaves over time. When it started, where it began, and how it changed. What made it worse, and whether overall picture is progressing or stabilizing. Two patients can report the exact same symptoms, and one may go home safely while the other goes to the operating room. That difference isn't intuition, it's pattern recognition, built on time, trajectory, and risk. When surgeons think about appendicitis, we're not asking, does this patient have the classic symptoms? We're asking something very different. Is this pattern behaving like a progressing inflammatory process or not? That's why migration of pain matters more than location alone. Why worsening pain matters more than pain intensity. Why time matters more than tenderness. Appendicitis is rarely a moment, it is a sequence. Early irritation produces vague discomfort. Local inflammation sharpens it. Peritoneal involvement changes how the body reacts. Symptoms aren't read individually, they are interpreted as a timeline. And the surgeon's job is to decide whether that timeline suggests escalation or whether it safely allows observation. When people talk about appendicitis symptoms, they usually want a list. But surgeons don't think in lists, we think in signals. That said, there are several symptoms that commonly appear, and understanding why they appear matters far more than memorizing them. Pain is usually the first signal. Early on, it can be vague to localize. As inflammation progresses, the pain may become more focused, often towards the right lower abdomen, though anatomy and timing can change that. Loss of appetite is a very important symptom. A useful way to think about this is sunburned skin doesn't want to be in the sun. In the same way, inflamed intestines don't want to work. When the bowel wall becomes irritated, normal digestive activity slows down. The body suppresses appetite, not as a coincidence, but as a protective response. Nausea can accompany this, not because the stomach itself is diseased, but because inflammation in one part of the abdomen affects the entire system. Movement-related pain is another important signal. As inflammation spreads, it can begin to irritate the peritoneum, the lining of the abdominal wall. When that lining becomes involved, actions like walking, coughing, or changing position may worsen discomfort. Fever can appear at different stages. It may be mild or significant, early or late. But in most cases, fever tends to develop after the pain has begun and not before. Not all of these symptoms appear in every patient, which is why no single symptom confirms or excludes appendicitis. What matters is whether the overall picture is evolving in a way that suggests progression. Imagine two people arriving at the emergency department on the same day. Both describe right-sided abdominal pain. Both mention nausea. Both are concerned about appendicitis. In the first case, the pain began suddenly in the lower right abdomen. It comes in waves, severe at times and then easing off. The person feels restless, uncomfortable lying still, and keeps shifting position to trying to find relief. In the second case, the pain began vaguely, more centrally, and gradually intensified over several hours. It doesn't come and go, it steadily worsens. Movement makes it more uncomfortable, not less. On the surface, both stories include right-sided pain, but the patterns are completely different. Later evaluation shows that the first pattern was not appendicitis at all. It was a kidney stone. The second pattern reflected a progressing inflammatory process. Neither diagnosis came from a single symptom. They came from understanding how pain behaves over time with movement and in relation to the body's response. That is the complexity of abdominal symptoms. From a surgical perspective, symptoms are never treated as answers. They are treated as inputs. Appendicitis is not diagnosed by pain, location, nausea, or fever alone, and it's not ruled out by the absence of any single one either. What matters is whether the overall pattern suggests progression, a picture that evolves, intensifies, and becomes more localized over time, raises concern. A picture that fluctuates, migrates unpredictably, or improves may point in a different direction. This is why appendicitis is not something confirmed by symptoms at home, and not something dismissed by a normal moment either. The role of symptoms is to signal risk, not to make decisions. And the role of clinicians is to interpret those signals within a system designed to tolerate uncertainty safely. One of the hardest parts of appendicitis is that both of these statements are true at the same time. Appendicitis can look very subtle early on, and appendicitis can become dangerous if progression is missed. That tension is what creates anxiety for patients and clinicians alike. Most abdominal pain is not appendicitis, but when appendicitis is present, time and trajectory matters. This is why modern care often involves reassessment rather than instant decisions. Symptoms are allowed to declare themselves. Patterns are observed. Change is often more informative than a snapshot. This approach isn't hesitation. It's how uncertainty is managed safely, by watching the direction of the story, not just the opening chapter. Appendicitis is often talked about as a diagnosis made by finding the right symptom. In reality, it's recognized by understanding the right pattern. Pain location matters, but less than pain behavior. Fever matters, but usually after the pain begins. Nausea matters, but appetite loss often matters more. No single symptom confirms appendicitis, and no single missing symptom rules it out. What guides concern is progression over time. That's how surgeons think about symptoms, not as a checklist, but as a story that unfolds, and understanding that difference explains why appendicitis can be difficult, uncertain, and sometimes deceptive, even in experienced hands.